close. We're close.
So a question has come up that I just wanted to address before we get started with our final panel of the day. Last but not least, we're going to talk about issues around health equity and school nurses' role in ensuring that every child receives the health services that they need. But really quickly, I just wanted to say that there are parking vouchers available if you parked in the grand garage next door. Those are available out near the registration desk, so if you need that, feel free to come and see me. Also, please don't forget to write down what is next? What should the next collaboration between NASN and the Network for Public Health Law be on those index cards? Is it pushing for ratio laws? Is it pushing for funding? What are the policy interventions that need to happen? And hand those to me or drop them on the registration desk on your way out. And finally, I've gotten a lot of questions about PowerPoints. The PowerPoint presentations will be made available to all of the attendees, as well as a link to the recording of the entire symposium, so you can share it with your colleagues who were not able to be here. It has been recorded and has been live streamed all day. So without further ado, I think Carolyn, are you up? Who's first? Can't remember. Carolyn. I think you're first.
I'm sorry. No, that's fine. Great. Good afternoon, everyone.
Good afternoon.
All right, let me practice this before I mess up things. Okay. All right, it's such a great honor and pleasure to be here this afternoon, so thank you, Carrie, and everyone else who coordinated this and inviting me to speak about this topic that has become dear and close to my heart in the last year or two. And I was invited to talk kind of in general terms, what is the role of a school health nurse in addressing access for underserved children and adolescents. So, and just before I start, I want to just make a disclosure. I work for the federal government, but today I am not here in that capacity. I'm here I'm in the role of the Robert Wood Johnson Public Health Nurse Leader, and therefore any views expressed in this presentation do not necessarily represent the views of the Health Resources Services Administration, the Department of Health and Human Services of the United States. And he understands what I'm talking about. So I'm not here as a federal employee today, so do not quote me. Okay, so I thought before we talk about access, we have to first define what is health equity. And this is something that I think before we've kind of struggled with what is equity versus equality and what is the real reality. And the reality is that on the far right, we know that we have different opportunities for different people, but equality is where everyone gets the same resources, despite your opportunities, despite of where you live, what you already have. And therefore we see that even though we spread out the wealth to everyone, not everyone gets the same opportunities. But equity is whereby we look at what are the needs and be able to kind of spread out the wealth or spread out those resources so that everyone gets an opportunity. The reality, however, especially when I think about Baltimore City, before I went to the federal government, I worked at Baltimore City Health Department, and I call Baltimore the city of two tales. And it's the city of two tales because when we look at life expectancy in two communities that are less than 10 miles apart, a 20 years life expectancy difference. And then the children, the infants in one community, the poor community, are dying 4 times more than the ones in the rich community. So these are social determinants these are health disparities that we have to address to be able to attain good health. And so talking about social determinants of health, this is something that, a phrase that kind of got all popular in the last couple of years, even though nurses have been addressing this forever. But we know that health outcomes are not just determined by just what we eat or the policy or where we live. It's also what we decide to do or what we choose to do, what we eat at home. It's all that, including the policies, the programs we choose to implement, the health factors which include where we live, which is the physical environment. And I'm glad that this morning you had a conversation about health environments. And then it's also the clinical care that we have, and that's what we'll be focusing on today, the access piece of it, the health behaviors, but also those socioeconomic factors that influence how our health will be. So as nurses, what can we do? I think nurses, school health nurses especially, you are the ones who probably will be the only source of care for most of the children that you see, especially the underserved ones. They probably do not have primary care, but because they have to come to school, they have to get immunizations, they have to get their hearing checked, they have to get their vision checked. And so how can nurses be able to what is the role of nurses to be in addressing care and making sure that access is for everyone, not just for a few privileged ones? So we have to have comprehensive systems or frameworks that address health overall. And health is, as we said, it's not just being able to access that care. It's also making sure that we have a play, every key stakeholder, and everyone is a stakeholder when it comes to health, is involved in that process. So we have I like this framework, the Culture of Health framework. It has 4 action areas, and they all kind of tie into each other, and they have drivers. If you haven't seen this, please check it out. It's a nice framework that kind of helps to involve everyone who would be otherwise not involved. So it involves the policies, the health in all policies, making sure that we have collaborations that improve health, making sure that we have integrated our systems. That way we are not forcing parents to go from one place to another to get care, which can be a barrier to most of the parents, or making sure that at the school level, what services are we providing, and are they coordinated? Are those children able to come to the health clinic and be able to get all the services that they need? Are they able to access the other services that are not available in the health suite? And it's also creating this healthier, more equitable communities. And how do we do that? It's making sure that we have policies that influence that. Policies that will promote people being able to believe in their communities, being able to know that they can be able to do something about their communities, to improve their environment, to improve their access, and so forth. And it's not all about the patient being able to access things. We have to make sure that the structural barriers that exist are also addressed. And so this framework, this is not what I'll be concentrating on today, but we'll be talking about what is the role of school health nurses. But this is a framework where nurses can be involved in each and every one of these action areas to improve health, well-being, and health equity. So what are school health nurses? As I've been going around the state, we've been, talking to different people. We've been hearing different kinds of stories. Nurses are not understood. People do not understand what is the role of nurses. A lot of people think school health nurses, you just do Band-Aids. You kind of just do all, you just deal with the little runny noses and all that kind of stuff. But nurses are more than that. They are the advocates. When those children come to your health suite, they probably have never seen another health professional before you. So when you may be the first person who those kids will have be able to talk to about their issues that are going on at home. So you'll be the advocate. You may be the health educator for that child or also their family. You may have to be the supporter, providing that family support to that family that is struggling. And also you might have to be the one to empower that family to care about their health and to know that they're able and they're capable of addressing their health. And outreaching to the students or the families that are struggling. Quality assurance, making sure that the services that you're providing quality. We're not just doing things for the sake of doing them, and evaluating them to make sure that we're getting the best bang for our buck. And coordinating services. I heard when I walked in, someone talking about care coordination and case management. These children sometimes have very complex health issues, and they need care coordination. And sometimes that's what the school health nurse will be able to do. And making referrals, and as well as being counselors to those children. But some of the core roles of school health nurses, I liked this diagram that is created here by by some pediatric group. But it says school health nurses provide direct care to students. They also provide the screening, and they also promote health by providing health education. They are the leadership in providing those health services. Sometimes you're the expert in that whole school when it comes to health issues. So nurses, be prepared, know your stuff. You're the one who probably the school will come to. Whenever there's a health issue, they'll always go to the school nurse. When kids have a health issue, they'll always go to the school nurse. And they're also the ones who promote, be the leader in the policies and programs. So if you're not familiar with what's going on or what the policies are, I'm glad there was someone to talk about, the Medicaid and other access issues as well as illegal issues. But we have to be able to be familiar with what's going on around us so that we are able to advocate for our communities, which in this case is the children in the school, the vulnerable children in the school, as well as being the liaison between the school, the family, the healthcare community, as well as the community in general. So the main reason I'm here today is to talk about what are some of the examples that we have right here in Maryland. I'm part of a project that we are with Robert Wood Johnson that we are enumerating and characterizing the public health nursing workforce in Maryland, and that includes school health nurses. So we did interviews with local health department leaders as well as school health nurse leaders, and we were able to interview about 19 local health departments and surveyed nurses and school health nurses and got about 541, is that correct, 541? 541 survey responses. And out of those interviews, we were able to get some exemplars of what were nurses already doing, because the question was, who are the nurses? First of all, in Maryland, we do not clearly know who are the public health nurses. That includes the school health nurses. And where are they working? And what are they doing? So we asked the public health nurse leaders and the school health nurse leaders, what are you guys doing in your local jurisdiction to promote health, to build a culture of health? And these are some of the examples that we were able to get. So quite a few of the jurisdictions had some school-based health and wellness centers, and I'll not talk much about that because I think someone will be presenting on that. So, and then there were quite a few telehealth programs. And why are telehealth programs important? This helps with you guys talked about absenteeism this morning, and so that helps with kids staying in the school, getting their care within the school instead of being absent from school or their parents having to not go to work because their kids are sick. And I think you'll be talking more about telehealth. So this is kind of just capturing it all, and then my other co-speakers will be getting into the details of some of these programs. But they also had 2 or 3 of the jurisdictions had behavioral health programs. This was very exciting to me to hear that some of the programs in the school addressing mental health within the school system. They're assessing for it and providing the services to the kids right within the school, instead of waiting for things to escalate and then we don't know what to do with a troubled child. These services are being provided right at the school. And then there were a lot of collaborations. A lot of the school health nurses said they were not working alone. They were working with different collaboration. They had partnerships where they were referring kids. They've established relationships whereby they can be able to refer kids to other services. In one of the rural counties, they did not have any specialty care for special needs care kids, and they were able to get those services to that rural area by just having collaborations and partnerships with different people. There was also one of the counties that had Care for Kids program. This is an insurance program for Medicaid ineligible and undocumented children who are under 21. So most of those kids did not have anywhere else to go for services. So the county decided that this was important enough and set aside some monies to support those kids. And other examples were school readiness programs, as well as one of the rural counties had a juvenile detention camp that children or vulnerable children who were sent to some jail, I guess, they were able to get healthcare services from nurses in that detention camp. There's so many other examples that we were able to get, and I couldn't put them all in one slide, and I couldn't get into details because it's just a lot of great work that is going on just within our jurisdictions. And I think the encouragement today is that there's still a lot to do. there are still a lot of barriers, but we have to use our barriers to make them into opportunities to do even more, to make sure that we are embracing health and making sure that we are promoting health in the most vulnerable. And those children, when they are educated, when they are empowered to know that they can do it on their own, they're able to also teach their parents. They're able to not only improve their health, but improve the health of their families as well as their communities. And I believe that's about it. Did I make time? All right. And last but not least, happy nurses.
Thank you. Good afternoon. My name's Barb Masulis, and I am the supervisor for school-based health centers in Baltimore County Public Schools. And I am also, involved in the Maryland Assembly on School-Based Health Care. And the Maryland Assembly on School-Based Health Care is the advocacy and support group for school-based health centers in the state of Maryland. And we've have an outstanding group of school health leaders and school-based health center administrators right here in the audience. And I acknowledge my colleagues as being very supportive of the cause of school-based health centers and helping advance it in the state of Maryland. So if I can get the technology going, my goal for this afternoon is to help people become more familiar with school-based health centers, to describe how school-based health centers can help reduce health inequities, and also to discuss the benefits and challenges facing school-based health centers today. So to get us all on the same page, what is a school-based health center? A school-based health center is a health center located in a school or on a school campus which provides primary and preventative health care. Additional services that may be included are mental health, oral, substance abuse services. And our main goal is to support student success by reducing health barriers that might be impeding their learning in school. So what is a school-based health center in terms of, we describe it as an extension of the school health program. It developed in the 1960s to address specific public health concerns. For example, in Baltimore County, we started school-based health centers to address the needs of pregnant teens who were having barriers to access to health care. And over the years, in the 70s, 80s, and especially in the 2000s, we've seen a tremendous increase in the number of school-based health centers. And the school-based health centers are becoming more comprehensive in terms of the services they provide. We describe ourselves also as a safety net provider for children and adolescents, especially those who are uninsured, underinsured, or who have geographic barriers to health care. So to give you some examples and to sort of highlight what a school-based health center is, I thought I would share some of our stories of some students that we've recently seen in our clinics in Baltimore County. One of the things we've noticed in Baltimore County is we're having a changing population. We have an increased number of immigrant students they come to our schools with a number of language issues, and also one of the big issues is they don't have the immunizations that are required for entry into a Maryland school. I'm going to tell you about our first gentleman, Juan. He came to our wellness center needing immunizations. He was referred to the school nurse. And our nurse practitioner was doing an assessment and noticed that Juan was very quiet, just seemed a little withdrawn, and she tried as best she could in a combination of English and Spanish to ask Juan about what his concerns were today. And Juan had come from El Salvador, and he was complaining of dental pain. He lived with his dad, and mom was still in El Salvador. And he had had this problem, just his jaw hurt, he was having a lot of discomfort. And he had talked to his father about it, and his father said, well, we'll save up some money to send you back to El Salvador so that we could get free dental care there. So we'll have you go back and see your mother, and we'll also take care of your dental needs. So the nurse practitioner did an assessment and found that he had large dental cavities. And she called the dad and said, we can probably work out getting him some care in the States, and we really need to have this problem addressed soon because this could advance into a very serious problem. So the dad hesitated and said, no, I really would like him to go back to El Salvador. So the nurse practitioner said, give me an opportunity to investigate options. So she called our health department, got a list of dental providers that would provide care at reduced costs, worked it out, got Juan an appointment at a dental health clinic for a very reduced cost. Juan was sitting in the dental chair. The dentist said, we're going to have to take out those 2 teeth. That's the only way we can address this problem for you. And the next thing they knew, Juan was out the door. He was not going to have anything in terms of having his teeth extracted. So once again, we called him down to the wellness center. The nurse our nurse practitioner and the school nurse did some real good negotiating. We got him back. Juan now has a smiling face. His immunizations are up to date, and he actually is going for a sports physical to participate in a team next year. So I also want to talk to you about Sarah. Sarah's a youngster who came to one of our schools from out of state. Medicaid had lapsed. She had a history of asthma. One day she appeared into the school nurse's suite having an asthma attack. And fortunately, she had a consent to be seen in the wellness center. And we were able to assess the asthma, write orders for her to have an inhaler in school, and dispense that inhaler. Tina is a little sadder story. She's another young lady who came from Central America, and the nurse practitioner was giving her immunizations to be in school. And during the interview, another sad face, and we had identified that Tina was a victim of sexual exploitation. What we did is we did STI assessment. We got her involved in mental health services within the school. And now Tina is a regular visitor to the wellness center. She's developed a relationship with the nurse practitioner. She is feeling much more comfortable being in school, and described as another success story for us. So I hope you have a sense of the kind of things how we work with the school nurse to achieve health care for our students. So some of the services provided in a school-based health center are comprehensive health assessments, and we do in Maryland. We follow the EPSTD schedule of required components. We treat acute illnesses. We monitor and care for chronic health concerns. We do sports physicals, immunizations, anticipatory guidance, reproductive health, nutrition counseling, and mental health services. Some of the common characteristics of school-based health centers, now there are a lot of us in the field that say if you look at one school-based health center, you're looking at one school-based health center. They're really sort of the nature of the school community. But we do try to become very integral part of the school community. We're not only providing care to the students, but also in some sites we're providing care to the school employees and also providing primary prevention in terms of health education to the school community. We require parent consent for a student to be seen. We employ a multidisciplinary team depending on the needs of that particular school community and the type of school-based health center it is. We are commonly located in schools that are Title I, high percentage of free and reduced meals, high mobility rates, and in Baltimore County, as I mentioned, we're seeing a need to have school-based health centers where there's a high immigrant population. Why school-based health centers? Dr. Durant and our keynote clearly identified why school-based health centers are needed. It takes a team to address some of the complex health issues that our students are facing. We all know that about 15% of children come to school with one or more health problems. We know that adolescents, for some reason, they drop off in terms of reaching primary care, and there's so many issues that can be identified just doing a sports physical on an adolescent that we can identify and treat and help them be more productive in their school. We can increase health access, and as my predecessor said, healthy students become better learners. So there's various models of school-based health centers across the country. Some provide only primary care. Some provide primary care with mental health services, and some have a whole range of services, including things like substance abuse, social services, dental care. And we're seeing a growth, here, especially here in Maryland, of school-based health centers that provide telehealth. And a key component of a school-based health center team is the school nurse. She's the person who's going to identify students who will benefit from your program and also help in terms of marketing the program. School-based health centers nationally by the numbers, and this data is from the 2013-14 School-Based Health Alliance national census. There's approximately 2,300 school-based health centers in the United States. There's been a 20% increase in the number of school-based health centers just since their last census in 2011. And 94% of those school-based health centers are located in a traditional school, whether it's a K through 12 or 9 through 12. Here's a map to sort of outline where school-based health centers are, and you can see there's a large proponent in the East Coast. In Maryland, we have 84 school-based health centers. I believe there's about 6 of those that are telehealth, and that's primarily in Howard County and on the Eastern Shore. So some of the sponsoring agency for school-based health centers can be hospital, medical center, community health center, FQHC, local health departments, school system, profit and nonprofit groups. So what are the benefits of a school-based health center? And there's literature out there and data that has shown that we have decreased emergency room visits and hospitalizations for chronic health problems like asthma. We have increased immunization rates. Once again, we have the students as a captive audience right there. We hope to improve academic success by reducing absenteeism and identifying any health problems that might be interfering with the student being able to attend and ready for school. And we provide increased access to things like mental health services and reproductive health that a lot of young people might not be able to search out because they're afraid of their parents' reaction or don't know how to reach out and get reproductive health. So school-based health centers, we have the students there 6 to 7 hours a day. Even though I would have to say in my population, in my school-based health centers, the students who need my services the most are the ones who don't come every day and require a lot of extra coaching and support from our whole team. We help families apply for health insurance. If they're eligible, we have outreach workers that can help them get re-enrolled. We have early identification of health concerns that can be addressed and, once again, reduce those health barriers. We provide care on a sliding fee scale for families with limited resources, and we also refer parents to help them find a medical home. We have a lot of challenges in school-based health centers. We have to have support from a number of different resources. We do bill for services. We bill medical assistance. We bill private insurances. But what we get in reimbursements don't cover the cost of our programs. So it's a challenge. But I've been fortunate in Baltimore County. We have a ton of support for our program, and the benefits really outweigh the impact on the school system. So sometimes we have the barriers that education and health may not share the same priorities. I think you probably have all seen examples of this. And sometimes what we've had to do is really approach the school principal and say how we as a school-based health center can help your school grow and flourish. And we really need care coordination between primary health and health insurance providers. One of the things we want to do is don't duplicate services, don't duplicate vaccinations. So I would love to see in the future some way that we could share information so that we knew that if a student who is enrolled in one MCO had a sports physical or a physical, we wouldn't duplicate that. So to summarize, I believe that school-based health centers are a model that provides quality care to diverse and underserved populations. We've increased healthcare access to a number of students and address a number of various concerns. I think some things we're going to see in the future for school-based health centers, they're going to be more community focused, meaning not only serving the students, but also maybe families, parents, any needs in the community. And we're also probably going to see a growth in telemedicine. So thank you. Oh, and if you have any questions, feel free to contact me. I think I got it. Oh, thanks.
That was a great information, and I'll leave your contact information up so that people can see it. That, and I also don't have a PowerPoint. So that'll work out. So about 10 years ago, I was a high school principal, and as luck would have it, within a week of earning my doctoral degree, one of my children got into a bicycle accident in the neighborhood. And my wife at the time, who had been providing pretty much all of the health care in our household, rushed to see my daughter, who had skinned knees and not any serious injury, thankfully. And our daughter rebuked her medical care. And she said, "I want to see Daddy," because he's a doctor. Which goes to show the significant lack of qualifications that I have to give this talk today, as well as to administer medical care to my own children, and to accentuate the value that we place on our nurses in our schools and in our communities. And I want to thank you for the opportunity to be here. I'm a school administrator. I supervise in my very large school system as the chief of schools, everything from the daily administration and instruction of our school system to information technology support and school nursing and student health. So along those lines, I try to find commonalities wherever I possibly can. So much like tech support, and if you can think about this for a second, as tech support like this, when everything is working really well, we all ask the question, God, why do we need tech support? But when things aren't working so well, God, why isn't there enough tech support, right? A lot could be said for school nurses as well. When everything's working well, school nurses sometimes fly below the radar, but when things aren't working so well, that's when we really call upon our school nurses into action. So for that and a great many other things, I join you in celebrating National School Nurse Day this week and tomorrow. And that also kind of brings me to the why I'm here today. And as I said earlier, I lack any qualification to be here today, and I am your least qualified speaker today. By far, so much so that my darling director of student health, Tia Campbell, in the back of the room right there, you should wave at this point. She really is the one who should be speaking today. And I think she invoked supervisor privilege in pushing me up here. So anything that I get wrong today, you can certainly blame on her. But that being said, the why is really important. And in my failings in terms of understanding the ins and outs of everything that you do on a regular basis and what you do for our kids, the why is still the same. We are here to support the whole child, and we are here to make sure that our children have an optimal learning environment and learn in a safe and productive way. And we cannot do that unless our kids are healthy and well provided for. Which brings me to Brad Pitt. And I should warn you, you know it's serious business when a school administrator uses a sports analogy. So here's my sports analogy for today, and the other guy in the room, or other two guys in the room, might appreciate some of this. Down the street a few blocks, they play this silly little game with a ball and a stick. at Camden Yards baseball. And I'm not that big of a baseball fan, but I do appreciate a lot of passion that goes into baseball. One of my favorite movies of late is a game with Brad Pitt, or not a game, a movie with Brad Pitt called Moneyball. Maybe you've heard of it. And it was based on a book, and it was actually a statistics book about how a major league team turned around their terrible franchise and made it a winning franchise, all based on using statistics to their advantage. And the key statistic that they used was called on-base percentage. The more times a player made it on base, the more valuable they were, and thus they would win more games. Turns out that was a pretty accurate assessment. Well, and this is how this ties into school. I think that one of the key statistics that we should be using and thinking about when we think about our kids is their on-base percentage. How frequently they're in school, also known as their attendance. Our students are more likely to be successful. They are more likely to learn. They are more likely to receive the information that we want to give them if they are in school or where we know we can deliver that information. The school nurse is critical to making sure that we have a high percentage of on-base participation or school attendance. So with that, I thought I'd just describe very briefly a little bit about our school system. And like I said, I run the day-to-day operations of a very large school division in Virginia, Virginia's fourth largest school division. We have about 60,000 students, and we're growing. We're right outside of Richmond, Virginia, the capital, so we are the large suburban center for Richmond, Virginia. We have 64 school sites, and several of our schools actually have multiple buildings. So our school buildings actually number close to about 70 in terms of actual sites where we're servicing the needs of kids. That's a lot of different places where we've got little pockets of about 1,000 little bodies running around that need our help. And with that, we have not had a school nurse in every building, and that seems hard to believe. So much so that in the job that I'm in right now, I've only been here about a year in my current position. I've never worked in a school system in 5 different school systems that didn't have a school nurse in every building. I was astonished when I came to Chesterfield County to find out that we didn't have a school nurse in every building. And there were a number of challenges that supported not having a school nurse in every building, and we're all familiar with those. You don't have to look back very far in history to see the fiscal retrenchment of 2008, 2009, to look for root cause analysis as to why there were challenges to that. On top of that, we have a very conservative community in terms of local politics. The community did not support hiring government anything, let alone public health. That being said, we did use some of Virginia's money. They do have an allocation in state funds for public health and school nursing. We did use some of those funds to support public health nurses in our school system. About 25 public health nurses were supported in our school system of 60,000 kids. And if you can think about that from a ratio standpoint, that's just terrible. Well, and that all kind of leads up into this past year where there was a significant impetus for change. And unfortunately, that significant impetus for change came on the heels of crisis. The loss of a child in a tragic situation, and the change in political climate, a positive shift towards looking at the whole child, a positive shift towards looking at student safety and student health, so much so that it led to a change in having our allocation go from public health nurses to school-based nurses. So all of our public health team shifted over, including its supervision and leadership. But really this was all at the center of trying to get to one key piece that we were aiming towards, which was to get a nurse in every school building, or at least every building where we were servicing children. I have to credit the change in the political landscape, and I have to credit our local school board and our, I should say, newly elected local school board for bringing in this desire to have a focus on the whole child. Because as we know, there are a lot of competing interests in trying to service the needs of kids, whether they be instructional or from a support standpoint, and that competition for funds is very fierce. When I look at Baltimore County right here, which is a fantastic school system led by a friend of mine, Dallas Dance, who came from Chesterfield County, Virginia, by the way, our per pupil expenditure is about 60% of what Baltimore County's is. And our targets for funding are very different in terms of our ratio and our ability to staff FTEs for anything, let alone whether it be social workers, psychologists, or school nurses, all of which are real needs in our school system. But another big shift that we were experiencing in our school system was also a changing demographic and growth. And in being responsive to our community's need for growth, and in being responsive to our changing demographic, and being more attuned to the needs of some of our English language learners, we saw this as a great opportunity to expand our student health services. We have an instructional coordinator on staff who works with social emotional learning. We have an instructional coordinator on staff who works with student health initiatives and student wellness. And we also have a director of student health who supervises all of our nurses. So much so that in the past fiscal year, we've grown from 25 health department nurses to 42 school-based nurses. We're not quite there yet, but we've added an additional 9 FTEs for the next fiscal year, and by fiscal year 21, we should be fully staffed with a nurse in every building, and some of our buildings even having more than one nurse. And part of that is to be responsive in our staffing, not just based on pure numbers, but also the chronic disease burden of each of our school buildings, and looking at the acuity of the need in each specific site, and not just the pure numbers of students, because our community is very diverse. We have a rural community, a suburban community, and also an urban community within our very large school system. So with that, I really, and it's a little bit of a misnomer here, because it says in your program that this was our one school division's success in funding school nurses for every school. Our success has really come from being smart about reallocating resources, whereas we had clinic assistants staffed in all of our schools. We have shifted a lot of that focus to nurses instead of clinic assistants, which certainly has changed the dynamic. It has come from local politicians that were willing to take the risk in favor of student safety. And also, I would say some of our success has come from supporting a leadership structure in place where we have nurse supervisors who are not school administrators. One thing that I'm delighted to tell you is that I am not qualified to supervise student health. I am hopefully smart enough to know that Tia is. And that we've hired outstanding leaders to lead our school nurses, and that work in conjunction with school administration instead of placing that role on school administration, who candidly lack the qualification to do adequate supervision. So with that, I give a lot of credit to our staff, and I give a lot of credit to our community for seeing the value in providing for our kids so that they can have a safe and productive learning environment. Thank you.
I hope everybody doesn't mind, but I actually do have slides that I'd like to share with you all. So let me pull those up. And one of our recipients, a telehealth expert, Mr. Mario Gutierrez, will be Skyping in from Sacramento. I'm going to talk about his grant program. Mario, can you hear me and see us? Just a test.
I was muted, but yes.
All
fine, and I
right.
can hear you.
Yay. Okay.
Want him to be able to share that as well?
No, not yet. I'm going to go ahead and talk first. Okay. Well, this is a wonderful opportunity for me to be here. Just a little background about myself. I was actually born in Baltimore, right across the street, so I love coming to Baltimore to visit every so often. Just a couple weeks ago, me and some colleagues visited the Kennedy Krieger Institute, right up the street, a few blocks up, doing excellent work with the telehealth, which I'll discuss more, and telehealth being as a valuable tool for schools, particularly for rural schools in high poverty areas, and it's a pilot program that I'm going to be talking more about. So my name is Carlos Mena. I am a public health analyst at the Health Resources and Services Administration, which is one of the 11 sister agencies in the Health and Human Services Department. You've heard of NIH, FDA, CDC, all the common three-letter acronyms. We don't have that cool three-letter acronym. We just called HRSA. But we do support a lot of safety net communities, workforce. One of our most popular programs, the Ryan White HIV/AIDS grant programs that serves every state and territory in the country. HRSA has about a $10.5 billion budget that puts out annually 95% of that in grant support, cooperative agreements, and contracts to support safety net communities and workforce, and of course the Ryan White HIV/AIDS Act, and telehealth, which I'm going to get into. Okay, I'll just use the mouse instead. Okay, there we go. So, I work in the Office for the Advancement of Telehealth. It is housed in HRSA within the Federal Office of Rural Health Policy. Our funds grants promoting telehealth technology in underserved areas to improve quality of care, increase access to care, provide more efficient resource use, and decreased travel time. So data, I should say. I've heard a lot of data talk early this morning, throughout the day. Very, very critical to us in proving that telehealth works, particularly for rural high poverty areas. It's very valuable. Is it cost effective? So all of the data that we've been collecting from our recipients since 2002 is invaluable in trying to translate that into dollars and cents. Is very important in showing that telehealth works as a tool to support clinical and healthcare education using computers, internet technology when distance separates the participants. We also fund research on the use of telehealth. We've supported UNC Chapel Hill. I think somebody in the audience is from Chapel Hill. Very important work in analyzing our previous cohorts and the information we get in providing summary reports to the public on the data that's received. We also coordinate what's called a FedTel work group where on a quarterly basis we partner with different federal departments and agencies to talk about pertinent telehealth issues. Between departments and agencies across the federal government, there is just over 10 different definitions of telehealth, 1 to 2 word nuance of how it's defined. Mario is going to present our standard definition that we use for the Office in Promoting Telehealth. So FedTel includes members like NASA, Department of Energy, Department of Commerce, and we'll sort of sit in a think tank and talk about priority issues involving telehealth and how it can support private and nonprofit organizations. So within the Federal of Rural Health Policy, where we're housed, we also have 3 other sister divisions. Our community-based division, our hospital state division, our policy and research division Again, all of these are grant programs supporting rural communities. Within my office for the advancement of telehealth is the Telehealth Network Grant Program, which is about a $6 million annual grant program. We're currently supporting 21 recipients across 19 states. I am the program coordinator, and my information will be presented on the last slide. So please call me or email me to talk about telehealth grant opportunities down the road that may be able to help you all in what you do for schools. Also, the Evidence-Based Telehealth Network Grant Program, that really looks at research for tele-emergency work that's going on. So if a patient has a stroke, lives 100 miles away from a hospital, and has the ambulance drive all the way to the hospital, well, can telehealth be used as an effective tool in treating that patient before it's too late? So it looks at those efforts. Veterans Flex Telehealth Program is a grant program that supports our rural veterans from the armed forces that live far from a specialist or primary care provider. It's particularly for the Veterans Administration, and they can go ahead and see, for example, a primary care provider at their local community health center for care through this grant program. So it's looking at how telehealth can be an effective tool for that. And Telehealth Resource Center grant program. These are based regionally, as well as we have 2 national telehealth resource centers. Mr. Mario Gutierrez represents he's our expert for policy, telehealth issues, reimbursement. So we often go to him for support on policy issues affecting states, on local level, state level, also federal level, and reimbursement. And they have a wonderful survey that he'll be touching on in one of his slides, 50-state survey on reimbursement. Currently for Medicaid, Medicaid supports 17 states for school-based telehealth. So it hasn't reached a tipping point, and our data is trying to show that it's effective for those rural communities, and hopefully Medicaid state offices that's for states that don't support it can turn that around. We also have 12 regional telehealth resource centers. So these are folks really that set the benchmark in telehealth, anything from answering questions or providing technical assistance for our HRSA grantees from, well, I've heard about telehealth, but not sure how it works. Or, well, I want to get started in telehealth, but I'm not sure what kind of equipment I should buy to provide security and privacy for the child or for the patient. What would be the best approach? Or I'm into telehealth, we kind of got the wheels in motion. We have memorandum of agreement signed with our partners, but we have a licensure issue where you have a physician practicing in one state and our state doesn't recognize that physician's license, and how do we get around solving that issue so that that physician in another state can provide telehealth services to our setting? And that segues into our licensure portability grant program that looks at reducing barriers towards practicing telemedicine across state lines, whether through regulations or policies or state laws. As I mentioned earlier, I am the program coordinator for the Telehealth Network Grant Program. This has been appropriated since 2005, so we've supported 7 cohorts today. In previous cohorts, it's been supporting all medical settings for all age cycles. With this new cohort that we started supporting September 1st, it's a 4-year project period. It's really focusing on rural high poverty schools. So it doesn't necessarily mean that the setting or the school has to be a school-based health center. Some of these high poverty rural schools may not even have a RN or NP available, just a counselor. But this isn't in the sense of supporting an organization or applicant where the rural school that they partnered with, they're going to buy a bunch of equipment for the telehealth, and let's say it's just kiosks, but there's nobody there to supplement the care for the child. That's not what this is about. There has to be a baseline in terms of supplementing the care for a child that needs medical attention. So if it's just a counselor, a health aide perhaps, that can supplement that care when the child is talking to a specialist using the technology that's in the school, that's okay. But we don't allow for a kiosk to be purchased and set up inside a hallway of a school for a child can, sort of like an iPad, can just, hit, okay, let me talk to whoever's on the other side of this. So this is very important to us, and because this is a pilot demonstration grant program, Congress is very interested in seeing the data that we get out of this program, even though it's a small pilot. It's just over $6 million per year for a 4-year project period. And there you have the amount of what the applicants have applied up to for, and it's supporting 21 recipients across 19 states. I do recommend folks to visit our website. It's HRSA.gov. And on there, if you just Google HRSA telehealth, there is a publication outlining, it's a summary report outlining what's been accomplished with the data that we've collected and analyzed. A nice summary report going back to 2004 to 2010 project periods. And within that report, one of the metrics that we collect data on every 6 months from our recipients is on patient travel miles saved. So how much, it's one of our best metrics in identifying the value of telehealth using the GSA Department of Labor mileage rate of 56 cents. So as you can see, from 2004 to 2010, just over $41 million was saved in patient travels miles. Again, this is supporting former cohorts that supported all age cycles in all types of settings. So we can't wait to see what we get out of the current cohort we're supporting with the recipients that are strictly supporting rural schools. And here's a nice map that I want to give credit to my colleague in the back corner, Stephanie Bagley, who just joined us a couple weeks ago. She developed this map for us, outlining in the blue highlights those states that are currently being supported through the Telehealth Network grant program. Some of those states, the Medicaid state office supports school-based telehealth reimbursement, but most of them do not. Another critical grant program that we've been supporting since fiscal year 2015 is the Rural Child Poverty Telehealth Network grant program. It's very similar to the Telehealth Network grant program, really supporting those high poverty rural schools. These are recipients down on the bottom of the slide that are currently being supported through next year. And going back to Mr. Mario Gutierrez's Telehealth Resource Centers, a consortium of 12 regional and 2 national resource centers. And there's a website if, depending on your region, I assume most of us are based in Maryland, Virginia, of course. We do have the Mid-Atlantic Telehealth Resource Center, which is funded for the University of Virginia in providing technical assistance on telehealth. So if you visit that website, or if you contact me, I'd be happy to give you more contact information for those respective resource centers. We also work with the FCC on their Mapping Broadband Health in America mapping tool. It's very important because it was designed to enable data-driven decision-making on broadband health policies and connected health solutions. So if you can highlight different types of data that you're looking for and really do a deep dive into what's considered rural and what's being supported through telehealth, through broadband, and how many patients and what's the patient population for a certain community or a local level or regional level based on this map. So I encourage you to visit that. HRSA also has a nice tool to find a telehealth provider on the website for folks that are trying to identify their nearest provider or community health center, if they're linking up with a rural school, how far that might be and what would be the patient travel miles saved if you were to opt for the telehealth. And telehealth is really boomed in the last 10 years significantly. Equipment costs have gone down, and the price of a computer or subscribing to Wi-Fi or broadband has gone down significantly. So more organizations we've seen over the years have taken advantage of adopting telehealth for what they do. Again, we support it and promote it as a tool for medicine and healthcare education. And this is our website. I have 1 minute left for folks interested in applying for any grants. And there's our director, Dr. William England, point of contact information for myself. So please contact me if you're interested in future grant opportunities. So I'm going to tag team with Mr. Mario Gutierrez, who's on Skype from Sacramento, and it's a real honor and pleasure to have him co-present with me on his initiatives.
Great. Hey, thank you, Carlos. And so you get to see in real time how this technology actually really works. So can you hear me okay? See me okay?
Not yet, Mr. Gutierrez, almost. We're getting there.
Let's see.
All right.
All right.
In grandeur. All right. I know you're running out of time, and I want to get right to the presentation. So let me just get to share screen here. Okay. Start. Okay. Are we up? All right, good. So I'm going to just highlight the items here on my presentation, but there are a few things I want to emphasize that Carlos touched on, specifically when it comes to school-based services. First, a few words about our center. We were created by the California Healthcare Foundation about 10 years ago to be an independent public interest location initially for California, on issues related to telehealth policy and reforming those laws and regulations to prepare us for the next century of services for this incredibly large and diverse state that is primarily rural. I think it's important to emphasize what the earlier speaker talked about in terms of equity. For many people, telehealth is some fancy technology, and it's all about, that's something else over there that they use to do healthcare. And our primary mission, which is central to how we think about telehealth policy, is that it's really a vehicle by which we can help to create greater equity of health access for quality, affordable care and services for all. So not just geographic barriers, but also language barriers, cultural barriers, disabilities, you name it. These technologies are being used in incredibly different creative ways to be able to bring healthcare to people where they need it at the appropriate time. Whoops, all right. So as Carlos mentioned, we are funded under the Federal Office of the Advancement of Telehealth, and we hope to continue to be funded. We just reapplied for our next 3-year grant. This is a screenshot of our website. I'm not into a lot of detail, but I believe we have the most comprehensive public access website on telehealth in the country. You can learn about just the basics about what telehealth is, what are the policy issues, legal issues, anything related to policy briefs related to state or federal policies. You can find on our website. So I certainly encourage you to visit it and surf around. If you're interested in getting on our mailing list, we have a weekly newsletter that we send out that provides the latest and new information related to telehealth and telehealth policy. So Carlos talked about the Resource Center. I think it's one of the biggest kept secrets in the country. We are a public access, a no-cost source of information on objective information on telehealth. Most people you're going to talk to are vendors trying to sell you equipment and services. Our resource centers are independent, objective, and with the interest of providing the best information possible so you can make informed decisions. We've just joined together as a national telehealth resource center because we believe the greatest resources that we have throughout the country should be available no matter where you may be located. And so telehealth is growing at such a rapid speed in so many different areas that as questions and issues come up, we have access to the greatest minds in all the country. And usually within 24 hours, we can get answers to questions and provide you with resources and support. So some of you may remember this from 1962. I think most of you in the audience are pretty young, but This is a program from the program The Jetsons. It was a weekly primetime cartoon series. And what I find remarkable about this is that this was 55 years ago. And you know, the concept of putting the child or the family at the center of the healthcare system and bringing resources and attention when they need it is something that we've all been dreaming about. And you know, now we have flat screen TVs, so that came to be. And we have some direct-to-consumer, but you know, really the kind of continuity of care for health and public health, we still haven't reached that the fantasy that those writers saw in 1962. It's not a new thing. That's the other thing I want to emphasize here. Telehealth has been around for a long time. Some of the more common uses of telehealth in terms of psychiatric care, dermatology, others have been around for decades. And so we're not talking about something new. What's been the challenge is bringing public policy along to be up to date with where the field is going in terms of telehealth. So yeah, I can define telehealth as the use of communications technology to bring care and services and health education at a distance using those technologies. But I think what's more important is to understand telehealth from the context of what the value it brings to patients, to providers of care, to payers of care, and to health systems. And I think the most important thing to take away from my presentation is that it's not a separate service. It's really something, it's using these technologies as a means for redistributing the scarce resources and expertise that we have to where it's needed, when it's needed, and gain the greatest value for those resources. And it manifests itself into three or four actual buckets of what we believe to be the greatest use of telehealth. Most people are familiar with the use of telehealth for providing diagnostic and treatment services. This can be done both in a live consultation between a primary care provider and a patient and a specialist, or it could be done asynchronously or store and forward, where you can send a picture, like for example on the right there, for dermatology, where it could be sent from a primary care physician to a dermatologist for review at a later time using secure email and getting a response back as to whether or not that patient needs to be seen and providing a diagnosis. With the resolution of cameras today on our smartphones, this is really becoming very common. The other thing is that important to keep in mind here is you know, you've all been talking today about how you bring more better and more effective care to the school and using the school as a place for the provision of care, and the importance of school nurses. The notion that school nurses are, you know, is a limited and valuable commodity in terms of how we can spread nurses to be able to provide care at every school. Through the uses of these technology, we can multiply the effectiveness of one school nurse in many schools to be able to provide the services in a way that is virtual and meets the needs of those children in those schools. So I think it's something that is particularly suited for school health programs. The second area that doesn't get as much attention, but you just talked about care coordination and using these technologies to be able to communicate between a patient and their provider, between a specialist and a primary care physician, and among the care team. I think we now have the ability so that the whole person can be treated. And as we heard earlier today, in terms of the social and environmental determinants, there are many factors that play into the care of an individual or a child, and being able to provide better care and more effective coordination using virtual technologies, both through audio and visual techniques. The third area, which is not as, I think, is relevant for school-based, but it's important to understand, is the use of remote monitoring, where the management of chronic diseases can be done in the home, and particularly for the aging population, to keep people healthy at home and prevent institutionalization and allow them to stay, particularly in rural communities, to be able to stay home with their families and their communities. Much of this is done using Bluetooth or broadband connectivity. On the right is probably the most sophisticated form of remote monitoring, which is also very important for rural communities in which the command center of an intensive care unit in a major hospital can provide that same service to rural hospitals through this kind of connectivity, and allow those hospitals to be viable and not to have to hire the expensive staff 24/7 to provide intensive care. This is also proven to be, meeting the triple aim of healthcare of saving money, getting the efficiencies, and providing high quality care. And the fourth, which is fast growing, is this whole notion of mobile health, being able to monitor your own health and having these kinds of different monitors, both in terms of smartphones and peripherals, such as what we use for like Fitbits and monitoring your steps and your exercise is becoming very effective, particularly when you can connect it back to your care team. And there's a continual loop of information, both in terms of understanding and monitoring the services. And then there's always the value of the convenience, not just for the patient, but apparently also for the docs. This is both to be humorous, but also to be serious, that the value of these resources allow us to get the maximum utilization of our providers 24/7. And so to the extent that now many commercial insurers are starting to contract with direct-to-consumer organizations so that there's the ability for a patient who has an issue to be able to utilize direct-to-consumer consultation without having to go to an emergency room and all the expenses associated with that. So let's talk about policy. You heard earlier a presentation related to the Medicaid program. States have full flexibility to utilize the Medicaid program as they're matched with federal dollars. And what that results in is, we have 50 states and DC, which each have their own policies related to Medicaid. And of course, if they're related to Medicaid, they each have their own policies related to telehealth, which creates a real nightmare. So one of the things that we've done as the National Telehealth Policy Resource Center is that we spend a good deal of time researching the policies, regulations, and pending legislation related to anything related to telehealth. And we keep this updated on a quarterly basis. It's the most comprehensive, up-to-date source of information you'll find in the country. You can just click on your state and be able to see what the laws and regulations are related to Maryland or any other state. We also do this according to a number of categories. So is it defined as telemedicine, which is very narrow, or does it incorporate telehealth, which includes mental health, dental health, physical therapy, the full range of healthcare and health education, which I think is where the field is headed. Do they reimburse for those different modalities that I described? What's their policy related to online prescribing? Consent is also a controversial issue. Should you get a consent from a patient before you utilize these services? Cross-state licensing, not just for physicians, Carlos spoke about the Federation of State Medical Boards and their compact related to cross-state licensing, but there's also the nursing compact, which allows nurses to operate in different states. And they've now, I think, up to 25 states have signed on to that compact. Private payer parity is another area that's very common across the states to ensure that payers treat telehealth in the same way as they do in-person care. And location and site transmission fee are two other areas. So when we've done our analysis over the years, we've seen gradual increases in states incorporating telehealth policies into their Medicaid programs and related to how services are provided. So we now have 44 states who actually have a definition of telemedicine, but only 33 states incorporate telehealth. So we have a long way to go. Some states have both, like Maryland, and so that's why you see the duplication. And we still have Alabama, New Jersey that still haven't figured out what they want to do yet. Parity, I mentioned before, is an area that has gotten a lot of attention. There are now 34 states who've signed on to this compact, which is not, just to be clear, it's not portability of a medical license. It allows a physician in one state to apply through the compact to practice medicine in another state. So it's designed to facilitate the process, but it's not true portability like the nursing compact. And one of the things that in terms of the prior payer laws, is that we require that states pay the same as they would for a telehealth visit. But in the context of parity, most states have this clause which says subject to the conditions in terms of the contract of the plan, which in essence gives them a loophole as big as a truck to drive through. And Maryland also has this provision, which again is very difficult to enforce. Just a couple of examples of projects or states that have done that have been progressive. Our work here in California led to the passage of the California Advancement Act of 2011, which replaced telemedicine with telehealth, incorporated the different modalities that we spoke of, removed the limit of where telehealth can be provided from usually from a medical or a hospital facility to include any place where a patient is located. So, for example, schools are now included. Also allows any licensed professional, not just physicians and a small pool of who is defined as who can provide these services, now allows any professional to provide telehealth services, and also added the private payer provision. I want to highlight Georgia Partnership for Telehealth. They're one of our resource centers in the Southeast. They have I think, one of the most advanced telehealth school-based programs in the country. They now are in 25 counties and 92 schools. So I would certainly encourage you to contact them directly and learn about their program, how they're set up, and how they get reimbursed, because they are the national experts, I think, in terms of school-based telehealth models. Just a few words about Maryland. This is right from our website. So confusing language in the Maryland law. There's a very nice definition of telemedicine, but then when it comes to reimbursement in your Medicaid program, it's defined only as telemedicine, and it's defined only in live video. So those other modalities that I described that increase the efficiency and effectiveness of care are not included as part of the Maryland reimbursement for telehealth. Also, there's a provision for what's called hub and spoke, which is a traditional model of telehealth where you have one center with many spoke provisions. Now we have the ability to be much more flexible. The one thing I do like is that it applies to both fee-for-service and managed care. We're seeing that managed care companies, particularly in Medicaid, are beginning to see the value of telehealth as a way of meeting their plan requirements, particularly for timely access. And then in terms of your covered services, somatic and behavioral health, which I think is good, but then requires every visit requires a prior authorization. You also have these other regulations related to consent, which I think are probably some of the most, I think, onerous or creates a greater barrier than other states, in which the telehealth provider not only must inform the patient and the consultant, but they also have to determine that there is no other available in-person care before they can use this. And then, there are a number of other barriers that I think that have created some disincentives for providers to be able to use telehealth in Maryland. So a ways to go. The other thing I'd like to mention in terms of policy is don't just look at telehealth laws and regulations in terms of what gets reimbursed, but the other players in the field are your regulatory agencies, and the courts are now playing a big role in defining for particular states. We've seen major court decisions in both Texas and Kansas related to whether or not an in-person visit needs to be had before a telehealth visit can be provided. And then the licensing boards, depending on what form of paraprofessional, whether it's occupational therapy or optometry or whatever it may be, are now using their regulations in terms of licensing to include under what conditions telehealth can be utilized. So it's important to look at licensing boards as well. So with that, there's our website. I know that was fairly quick. I know you're at your end of your day, and we certainly are available to answer any questions that you have directly by email or by phone, and certainly take full advantage of the telehealth resource centers. We are there to help, and I know it's pretty complicated when it comes to policies and regulations. I did mention federal policies because really there are no federal policies. Medicare is the last to the table in terms of recognizing the value of telehealth, and only less than 1% of the funding of Medicare goes to pay for telehealth, because it's only paid for live video in very strictly defined rural communities, which we hope will be changed over the coming years. And with that, I can stop and answer any questions you may have.
Great. Thank you, Mario, and all of our panelists. Do we have questions? We have 8 minutes. Oh, Denise.
Hi. This would be either for Mario or for Carlos or both. I know there's sometimes a tension and balance between security and applications and platforms that are user-friendly. When patients are receiving care from their home using their own computer equipment, how is the issue of security dealt with?
Let me just comment on that, and I'll let Carlos respond as well. The general rule of thumb is if the patient chooses to, it's their choice to utilize their own telephone or their own communication methods, that it's their choice. And so to some extent, they are understand that there are some risks involved with those forms of communication. By and large, we believe that when you set up a system, such a home-based system, that there are very secure systems that are in place that are HIPAA compliant. And I think that that has always been a minimum requirement that we've seen in any of the successful remote monitoring or home-based systems. But another, taking for example, like Kaiser Permanente, which is a major provider of care in California and other parts of the country. They now do 60% of all of their routine visits are done virtually by either telephone or by Skype, and patients are very comfortable with that and using their own iPhones or iPads or whatever it may be. Carlos, you have a comment?
Yeah, I concur with what Mario just said. And it's very important that as long as the security is there, then that exchange can occur between the patient and physician.
Okay, we'll just thank our panelists, and thank you, everybody. And Beth Maddie is going to close us out.
So I want to thank all of you all for coming, and thank you, panelists. This was just a wonderful day. Just so much information shared. So I'm going to just give all the panelists another round of applause, and thank you. Thank you, Carrie and the Public Health Law Network, for all the work that you did putting this together. It really has been beneficial. The link to this meeting will be emailed to all of you. So it was live streamed today, so you will get a recording for the day, the link to the recording. And all the PowerPoints as well will be on the Public Health Law Network, but that you will send a link for that as well. Action steps, do not forget things that came up today that you can think about. What action steps do we need to take moving forward? Where do we go from here? This partnership that we have, really, what can we do now? Please write on your cards and drop them off with Carrie on your way out. One last thing, I want to wish all school nurses a very, very happy School Nurse Day tomorrow, and I applaud you for all that you do. So thank you. So thank you all, and have safe travels home. Wonderful, you get what you need. This was great.
Thank you so much.
You see me?
Yes.